Hello everyone, welcome to Patho Excellence. In this endometrial pathology video series, today in episode 14 we are going to discuss endometrioid carcinoma and its variants. So today we will discuss histologic classification of endometrial carcinoma, endometrioid carcinoma in detail, endocervical adenocarcinoma versus endometrioid carcinoma, subtypes and metaplasias and variants of endometrioid carcinoma and different patterns of invasion. Why this multiple histologic subtypes is essential? So it is for the prognosis, surgical staging, chemotherapy response and hormonal therapy eligibility. And morphology must be integrated with IHC and molecular features for the subtype. So common histotypes are one which we are discussing today, endometrioid carcinoma, second is serous carcinoma and clear cell carcinoma. So let's see in detail in this endometrioid carcinoma. Second, high grade biphasic tumor which is carcinosarcoma, dedifferentiated carcinoma and undifferentiated carcinoma. And some rare important histotypes are neuroendocrine and mesonephric like carcinoma. These all tumors we will discuss in next episodes. So today we are going to discuss endometrioid carcinoma. It is most common histologic subtype. It is type 1 endometrial cancer, estrogen dependent tumor and usually low grade with favorable prognosis. Clinically, it is associated with the obesity, which is having increased peripheral estrogen conversion, nulliparity, unopposed estrogen therapy, tamoxifen use, and estrogen secreting ovarian tumors, because this tumor is associated with excessive estrogen. Hereditary associate is Lynch syndrome, Cowden syndrome, and other familial cancer syndrome. Clinically, patient present with uterine bleeding which is abnormal, and in perimenopausal or postmenopausal women. In younger women, if it is present, it is either having high BMI or presence of Lynch syndrome. Now, grossly, here the specimen shows either exophytic polypoidal mass, as we can see here. This is the exophytic polypoidal mass, and either flat or infiltrative plaque. So here this tumor is present in the areas of fundus as well as lateral uterine wall, and this is the cervix. This is the cut section of uterus with cervix showing irregular growth in the fundus and lateral uterine wall. Cut surface is tan to yellow, sometimes punctate hemorrhage is seen, and exophytic tumor is generally soft friable in nature, where invasive component is firm and rubbery. Myometrial invasion is difficult to assess grossly, but uh, it challenges during frozen sectioning reporting as well as intraoperative depth assessment. Some tumor shows either discrete nodule or nodules or focal undulation or irregularity of the endometrial surface. So it is called focal tumor pattern, which is localized in nature. If tumor is present in lower uterine segment, then it should raise high suspicion for Lynch syndrome associated endometrial carcinoma, and careful clinical and molecular correlation is advised. Now, whenever we want to see myometrial invasion, we have to look for whether it is irregularity at the junction or blurring of the junction endomyogenesis junction is there. So at that time we have to suspect myometrial invasion. So another is called occult or non-mass forming tumors. Sometimes it happens like when we get biopsy, then some tumor portion is there in the biopsy and we diagnose it as a endometrial carcinoma. But when we get hysterectomy specimen, there is no discrete mass or identifiable tumor grossly. So in these cases, we have to go for entire endometrial submission to detect microscopic carcinoma. Now, microscopically, this tumor is diagnosed based on architectural then cytology because it resembles normal endometrial glands. We have to look for gland density which is increased and there is loss of intervening stroma. Now, architectural diagnostic criteria include fused gland with loss of intervening stroma, gland lining shows stratified columnar epithelium, smooth glandular contour, and cells share a common apical border, and there is presence of cribriform glands and labyrinthine or maze-like pattern. If we see cytologically, then it is having moderate amount of eosinophilic granular cytoplasm, oval and basophilic nuclei, punctate nucleoli means small nucleoli, mild to moderate nuclear atypia. This point is very important because if severe nuclear atypia is there, it is generally seen in case of serous carcinoma and absence of marked pleomorphism. Now, we have to compare it with benign proliferative endometrium. Here, in this type of tumor, nuclear enlargement is there and increased chromatin irregularities is present. Absent feature include frank anaplasia, bizarre mitosis and prominent macronuclei. If these three features are present, then we have to go for serous carcinoma. Now, how to identify cribriforming pattern? So, commonly used criteria is either more than 2 or equal to 2 linear extent of fused glands or fused glands spanning 1 10x power filled. So, any of these criteria if present, it is called cribriforming of gland. Now, additional microscopic features are peripheral cribriforming as well as intraluminal neutrophil and necrotic debris and apical cytoplasmic clearing may be seen. Now, mild cytology and complex gland, it is suggestive of endometrioid carcinoma. Cribriform pattern, if it is seen, it distinguishes carcinoma from hyperplasia because hyperplasia is devoid of cribriforming pattern and severe atypia is there, we have to think of TP53 or POL mutation. Stromal invasion, which is key factor where stroma and background show forming macrophages in 50% cases as well as presence of tumor necrosis and endometrial intraepithelial neoplasia or atypical hyperplasia commonly present in estrogen driven tumors and absent hyperplasia if present we have to think of Lynch syndrome associated cancer. Now, frank myometrial invasion, it is not required for diagnosis, but stromal invasion is required, which is suggested by loss of stroma between glands. And desmoplastic response may be absent, so we have to carefully look for stromal invasion to diagnose endometrioid carcinoma. FIGO grading, which is low grade, intermediate grade, and high grade. and it is graded according to the proportion of non-squamous solid growth. This system already we have discussed in the previous episodes. So if you want to learn it in detail, then please see this episode 13. Now squamous modules are excluded from this assessment. So this is the section in low power showing glands in the labyrinthine pattern or maze-like pattern having complex architecture, back-to-back arrangement, loss of stroma, and here in high power view we can appreciate mild to moderate atypia, nuclear clearing and indistinct nucleoli. So this is grade 1. Again grade 1, this is macro gland formation here, and this is the lumen of the gland, and we can see here there is apical clearing. So cells are, nucleus are here basally located and apical clearings is present having elongated nucleoli. In high power view, this is again a macro gland, and in this having peripheral cribriforming pattern. So here cribriforming pattern is there, and this is showing necrotic debris as well as neutrophilic collection. Again grade 1 endometrioid carcinoma. This is the tumor part having mild to moderate atypia, but this is the normal endometrial gland entrapped in the tumor portion. Here some mitotic figures can be seen, and some bizarre looking cells are also seen. Now grade 2 endometrioid carcinoma. So grade 2 endometrioid carcinoma, it shows here solid component. So if whole tumor contains less than 50% of solid tumor mass, then it is grade 2. So here we can appreciate well formed glands are present, but some portion show solid pattern. So it is grade 2. Here grade 3 means more than 50% of the tumor showing solid growth pattern. No glandular architectural seen in this section, but it should be less than 50% glandular component and more than 50% solid component. If we find this type of pattern, we have to differentiate it from dedifferentiated carcinoma. So it is based on architecture, presence of gland and its biological behavior. So aggressive, abruptly lost gland and abrupt transition between solid and glandular pattern suggests dedifferentiated carcinoma. This is important, the nuclear upgrade clause, which shows that if glands are well formed or having mild cytological atypia, right. So here we can see well formed glands and nuclear atypia is mild to moderate, but some of the portion shows here in high power view marked atypia, pleomorphism, hyperchromasia, and this pattern is seen focally, then we have to grade this tumor, or we have to upgrade this grade 1 to grade 2 based on the nuclear atypia. So well formed gland and nuclear atypia, if both are seen, then it is grade 2. And this tumor is generally having TP53 and pole mutation in this case. This is endometrial carcinoma here these tumor glands are there, but here some collection of foamy cells are present. So this is suggestive of endometrial location, right? Whenever we get biopsy, whether it is having part of endometrial surface or from the cervical origin, if we have confusion, if this foamy cells are present, it suggests endometrial origin. Here this is a tumor gland showing intraluminal papillae. So it is suggestive of endometrioid carcinoma because nuclear features are mild to moderate in nature. If same features or intraluminal papilla is present and the surrounding gland show severe atypia or severe nuclear characteristic pleomorphism, mitosis, then we have to look for serous carcinoma. So difficult situations may sometimes lead to diagnostic challenges, which is curettage sample which is having scanty material or prominent villoglandular pattern which can be confused with serous carcinoma. Macrogland without internal complexity may sometimes uh, lead to underdiagnosis, and focal gland fusion if present also lead to underdiagnosis. At that time we have to go for immunohistochemistry and molecular features. Now what are the different markers which is expressive in endometrial carcinoma, like CK7 which confirms Mullerian origin, EMA epithelial marker, CA125 Mullerian differentiation, and BUR EP4 positive, it distinguished from mesenchymal tumors, and B72.3 positive, it supports adenocarcinoma. These all are positive in endometrioid carcinoma. ER and PR, which is hormone responsiveness suggestive, and less than around 50% of grade 3 carcinoma show decreased expression in endometrioid carcinoma, and PR is also same, positive in most cases and decrease in high grade tumor. So ER predicts hormone responsiveness where PR suggestive of prognostic and therapeutic relevance. Why maintain? Diffusely positive in endometrioid carcinoma which favor endometrial over cervical origin, so important IHC marker. And P53, it is wild type in grade 1, 2 and aberrant in subset of grade 3. So what is wild type? It is having patchy or few cells show expression, and aberrant in grade 3 means major portion of the cells show positivity, and if it is diffuse positive P53 alone, then it is serous carcinoma. Now molecular patterns like P10 mutation or loss is very common, while PIK3CA mutation, ARID1A mutation is common, and MMR deficiency associated with mostly MLH1 hypermethylation, and TP53 mutation seen in subset of high grade tumor. Hormone driven pathway, it is typically of type 1 endometrial carcinoma. Now differential diagnosis between endocervical adenocarcinoma and endometrioid carcinoma. So these are the features which can help us to reach the diagnosis, like clinically endocervical carcinoma present as a cervical mass, postcoital bleeding, vaginal discharge, here obesity and irregular menses, tumor stroma, here dense fibrostroma with large irregular vessels, here there is endometrial type stroma with foamy macrophages, Adjacent precursor lesions like adenocarcinoma in situ or squamous intraepithelial lesion which convert into invasive carcinoma. Here, endometrial intraepithelial neoplasia, EIN transit to carcinoma. Tumor cell features: high grade atypia compared to mild to moderate atypia in endometrioid carcinoma, and mitosis and apoptosis are frequent in endocervical where it is less frequent in endometrioid carcinoma. P16 diffuse strong positive, here patchy or focal positive. ERPR shows patchy positive or negative, while strong diffuse positivity in endometrioid carcinoma. Vimentin negative in endocervical while positive in endometrioid. CEA and HPV in situ hybridization, it is positive in endocervical while negative in endometrioid carcinoma. So here this is the IHC section showing endometrioid differentiation where vimentin is positive. Here it is P16 which is patchy positive. Some of the areas are spared and showing no positivity or no expression of P16. CEA is totally negative, suggestive of endometrial origin, and ER is also diffuse positive. So this immunophenotype supports the endometrial origin rather than the endocervical origin. So it is important to remember ERPR vimentin positive endometrial origin, P16 diffuse and HPV positivity endocervical origin. P53 positivity alone does not diagnose serous carcinoma, and loss of ERPR in grade 3 tumor does not exclude endometrioid carcinoma. Now let's look at metaplasia like normal endometrium carcinoma also show metaplasia, and this metaplasia does not change tumor classification. It may create diagnostic pitfall, and metaplasia is actually a supportive feature of endometrioid differentiation because serous, clear and mesonephric like carcinoma shows metaplasia very rarely. Now why metaplasia matters? Because mucinous or squamous metaplasia may mimic endocervical adenocarcinoma, where papillary syncytial metaplasia may mimic serous carcinoma. And extensive squamous metaplasia if present, it may falsely increase solid area and we can falsely overgrade the tumor. So here this is the endometrioid carcinoma with squamous differentiation, where we can find squamous modules along with this endometrioid malignant glands, and it is having rounded or spindle shaped cells. Sometimes keratinization is also present, and here eosinophilic cytoplasm is there. This is the section showing endometrioid carcinoma with atypical squamous differentiation. So here squamoid cells also having marked atypia, marked cytological atypia. So previously it is called adenosquamous carcinoma, but this is no longer an agreed upon diagnostic term, and this type of tumor is called endometrial carcinoma with atypical squamoid differentiation, and this tumor shows mismatch repair defect, and this case particularly was associated with germline MSH6 mutation. So these are the 4 different types of metaplasia like squamous already discussed, mucinous, papillary syncytial and tubal metaplasia, which is sometimes mimic in mucinous mimic endocervical and papillary syncytial mimic serous carcinoma. So we have to look for background endometrial glands as well as IHC panel. to differentiate it. Here in this section, this is the endometrioid malignant gland, but some of the cells show here forming macrophages, or sorry, mucinous mucin filled cells. So these are mucinous metaplasia in endometrial carcinoma. Here this endometrial carcinoma with secretory differentiation. Here these glands shows, some of the cells show subnuclear vacuoles and some of the cells show supranuclear as well as subnuclear vacuoles. So it is called secretory differentiation, and uh, care should be taken not to diagnose such case as a normal secretory carcinoma or normal secretory endometrium based on the low power view. We have to look for mitosis as well as Ki67 expression. If it is more than 50% of cells show this expression, it is suggestive of endometrioid carcinoma. And these tumors are hormone receptor positive, so ERPR is positive and napsin is negative, while clear cell carcinoma, it is having ERPR negative and napsin A positive. This is villoglandular architecture where finger-like projections or papillary formation with fine delicate fibrovascular core, and if complex pattern of this fibrovascular core and papilla is there with nuclear marked atypia, it is suggestive of serous carcinoma. So in this comparative sections of endometrial carcinoma, villoglandular architecture and serous carcinoma, we can see these are the papilla and having delicate fibrovascular core, where here complex papilla are there and in between there is marked pleomorphism and prominent nucleoli. So this is serous carcinoma and this is endometrioid carcinoma with villoglandular architecture. Some rare variants include ciliated cell variant, mimic tubule metaplasia, and prognosis is same with the low grade endometrioid carcinoma. Spindle cell variant, it is conventional glands plus spindle shaped epithelial cells. There is presence of fascicles or sheets of these spindle cells, but they are cytokeratin positive, suggestive of epithelial origin, and we have to differentiate it from endometrial stromal sarcoma. Third variety is corded or hyalinized variant, where there is cords or trabeculae or nest is present with hyalinized stroma. Peripheral, typically endometrioid glands are present, and it is often beta catenin or CTNNB1 mutation associated. Last is sex cord like variant, where cord nest tubules resembling ovarian sex cord tumors but low atypia, uniform cells, CK-IMA positive, but inhibin and carnitine which is negative or focal in endometrioid, while in ovarian origin it is positive. So here these four different variants. One is ciliated, where you can find cilia in the surrounding endometrioid glands showing cilia. Here uh, uh, two component, glandular component and spindle shaped fascicles are present. So this is spindle cell variant. Here corded and hyalinized, so these are the cord-like arrangement of the tumor cells, and centrally here we can find hyalinized material deposition, and in this sex cord-like variant these are the tubules and here the nest-like pattern arrangement of the cells in this variant. Now these are the four patterns of invasion or myometrial invasion, which is conventional infiltrative pattern, pushing or broad front, MELF pattern and melting pattern. These all four patterns are already discussed in detail in previous episodes, so you can go through this video and easily understand this pattern. This conventional pattern shows desmoplastic stromal response and easy to recognize and measure if we can identify endomyometrial junction. Pushing pattern, as the name suggests, it is blunt and bulky invasive front with minimal desmoplasia, but in this, because of a proper thickness is not measured and depth may be underestimated or overestimated in case of exophytic tumors. Now, MELF pattern means, as the name suggests, microcystic elongated fragmented. So, single glands either elongated or having fragmented outline, bland cells, and attenuated cytoplasm with myxoinflammatory stroma, which may be mistaken for lymphomuscular invasion and leading to underestimation of invasion. Now, adenoma malignum or melting pattern, where the single well differentiated glands or small groups of the malignant cells infiltrating without any stromal response. So, it may mimic adenomyosis and it may lead to underdiagnosis of invasion. So, whenever we see for pattern of invasion, we have to look for two things. One is junction. So, identify endomyo junction and identify stromal response. So, ultimately the take home message is that the endometrioid carcinoma is based mainly on the architecture and solid growth patterns defines the grade and molecular subtypes refine prognosis. So, I hope you like this video and you will now easily diagnose endometrioid carcinoma. So if you find it helpful, please like, share and subscribe this channel. In next video we will discuss serous carcinoma in detail. So thank you very much and stay tuned.